global network of collaborators. I work with collaborators in over 21 countries. So I always feel a little bit embarrassed just putting my name to something, but there are too many people to actually thank and acknowledge in this presentation. And when I hope all of you have realized that I'm talking about the Woman 2 program and not just a Woman 2 trial, because I think on the agenda it just said a Woman 2 trial. And so before starting my presentation, I want to just highlight why this program is important. And at the end of the Woman trial, we commissioned a piece of art, and the purpose of this art was to illustrate that every 6 minutes a woman dies from postpartum hemorrhage. And I don't know if you can see the little clock at the back. That just literally was counting how many women died in a day. And every 6 minutes, it tipped out 2 liters of blood into the baby bassinet that had actually had thousands of babies in its lifetime before it became part of this installation. So even now, women are dying every day. And on the first day of this conference, Jyrki said something that really resonated with me, because his presentation was about the epidemiology of postpartum hemorrhage. And what he actually said, I'm going to quote what he said. He said, PPH is the largest killer of women after childbirth, and especially when compounded by anemia. And what he said there is basically the rationale for the Woman 2 program. I don't think he intended to set out a rationale for us, but he did. And so we still need to find better ways of treating women who are dying in childbirth. So the Woman 2 program is focused on finding alternative routes to intravenous tranexamic acid. In the Woman trial, we only looked at intravenous tranexamic acid, with the hope that it will allow nurses and other healthcare professionals to be able to treat women earlier. And I'm going to present the importance of time to treatment when we're using tranexamic acid. And because time is so critical, we need to be thinking whether we can prevent PPH with tranexamic acid, especially in women who can least afford to lose any blood, and it's the women with severe anemia particularly I'm thinking about. So in the Woman trial, we saw that tranexamic acid reduced the risk of a woman bleeding to death about 30%, and it reduced the need for urgent surgery to control bleeding by more than 35%. But the treatment was only effective if it was given within 3 hours. So what is so special about this 3-hour mark? Why does it suddenly go from being effective to not being effective? But that's not really the case. It doesn't suddenly change at 3 hours. To look at the time to treatment interaction, we did an individual patient meta-analysis where we looked at for all trials that included more than 1,000 patients, where it was used in bleeding patients to reduce the risk of death from bleeding. And we had over 4,000 patients, but they were primarily from the Woman trial and from the CRASH 2 trial, which was our trial in trauma. And the trial in PPH and the trial in trauma actually showed identical results. When we looked at the time to treatment interaction, what we actually saw was that it didn't suddenly change at 3 hours, but that if treatment is given really early, within minutes of a woman giving birth, she has the potential of a 70% improvement in survival. But with every 15-minute we delay, we lose 10% of that benefit. And in fact, one thing to observe is that if you look at the confidence interval by 130 minutes, if you take the lower confidence interval, you might already not be having any effect. But the average effect is that by 3 hours, there is no benefit whatsoever. So time really is critical when we're treating women. And over the last couple of days, I've been listening to presentations about the emotive trial, for example, and there were questions around, with the package, why can't we give one at a time and look at the effect? Because obviously to give this package has cost implications. So, but for tranexamic acid, when you look at this, you can see exactly why you wouldn't want to wait and why it should be included in the primary response package, because there is no time to waste. Also, for a woman to benefit, she needs to be alive. And this is the data from the woman trial, where we had 483 women who died in the course of the trial. And this is only the data on the women who died on the first day. And as you can see, most deaths happen within 3 hours of a woman giving birth. So even if we forget everything to do with tranexamic acid and its time to treatment interaction, just looking at when women die should tell us when we need to intervene. One of a big barrier to women benefiting is the fact that it can only be given by an IV administration at the moment. That's the only data we have. And when the WHO updated their guidelines, one of the gaps that was identified was the need for alternative routes so that it can be used in more places. For example, where women give birth and there's no access to IV, but even in hospital, where nurses or midwives are not allowed to give IV drugs, and they have to wait until a doctor arrives. So even minutes really does count when you're giving tranexamic acid. So we want to see whether we can move this treatment from an IV. Obviously, the best way to give it would be an IV, because you will have 100% bioavailability. But if you can't do that, what else can you do? So the first thing we need to know was what concentration of tranexamic acid is needed to inhibit fibrinolysis. And using that information, then do a simulation and modeling to work out what would be the optimal dose and route. And then to test what we believe to be the best route and dose in a healthy volunteer study. Then repeat the modeling based on the data we have from real people, from the healthy volunteer study, but model how it might behave in a pregnant woman, because tranexamic acid is excreted renally. Also, women have higher circulatory volume, and around the time of delivery, their whole biology is changing. So we then will need to look at the dose and route that we identify in the healthy volunteer study to see whether it still holds true in postpartum women. So the first study we did, we looked at what concentration of tranexamic acid is needed to inhibit fibrinolysis. And this is looking at biomarkers in the blood that tells us about fibrinolysis. For example, D-dimers. And we found 21 studies included in the review. And we found that concentrations between 10 and 15 milligram per liter resulted in substantial inhibition of fibrinolysis, but even concentrations of 5 to 10 milligrams per liter were partially inhibitory. So using that information, we then did a modeling and simulation study, and to identify what would be the optimal dose and the optimal routes to use, the routes that we can take forward. Because the IV route is 100% bioavailable, we were interested in oral, IM, and subcutaneous routes. Okay, so for the oral route, if we, excuse me, if you look at the slide and the figure on your left-hand side, you will notice that the y-axis is very different in the two graphs. So please pay attention to that when you're comparing the two graphs. Oral tablets, in general, there were two studies that did the bioavailability of tranexamic acid using oral tablets. And you can see two studies so barely reached a partial inhibition of fibrinolysis at about an hour and a half, and two studies reached the substantial inhibition again, but it takes about an hour and a half to reach there. And in postpartum hemorrhage, that's just too long. So then we looked at solutions, oral solutions, because with oral solution, you don't need the tablet to break down, and the stomach transit time for liquids is much faster than a solid tablet. And even with the predicted lowest permeability and stomach transit time, that's a green line, we can still achieve the substantial inhibition levels in less than 30 minutes, which is really good. And we hope it's going to be somewhere between the two. So the modeling looks very promising for oral solution, but we've rejected tablets because that just takes too long. The front runner at the moment is intramuscular, because this is relatively easy to administer by most people. Anyone doing vaccinations, for example, will be used to giving an IM injection. And later on, we can even consider moving it on into auto-injectors, etc. But with intramuscular injection, especially if you have a woman bleeding and she's in shock, you worry about tissue absorption, because obviously blood supply is diverted away from the tissue. And if you look at the graph, the blue line, that's equivalent to worst case scenario, where you're really shocked and that blood supply is quite poor. And even at that level, with the slowest absorption rate, we can still achieve levels likely to exceed 15 microgram per mil in less than 15 minutes. But this is all modeling. So the next step was to move it into a healthy volunteer study. And this study would have been finished at the end of July. And sadly, because of the pandemic, we had to stop recruitment in March. And if you want to know more about the study, it's registered on clinicaltrials.gov. The routes we've taken forward are the oral solution and intramuscular, and to compare those against the intravenous route, because as I said before, that is 100% bioavailable. And very promising data in healthy volunteers that within sort of 15 minutes, we can reach levels. So this is real data from the trial. So in healthy volunteers, this is looking very promising. But the red line is something I forgot to mention earlier, which is to do with the subcutaneous route. We dismissed the subcutaneous route early with the oral tablets as well, because you will need about 20 mils volume injected into the subcutaneous tissue to reach, in a reasonable time, even partial inhibition. And in fact, this red line on this chart is we believe this person received their injection subcutaneously because it matches totally the line that we predicted would happen with subcutaneous injection. This one isn't part of the Woman 2 program. This is part of our trauma program, but I think it has relevance to postpartum women who are bleeding. Remember earlier I said, obviously, if you have a bleeding patient, you'll be worried about absorption from tissue, that's where the patient is likely to be in shock, and blood supply to tissues would be poor. But we did this study that has been submitted and hopefully will be in the public domain very soon. But in the meanwhile, you can find out more from clinicaltrials.gov. It showed that within 5 minutes of injection of 1 gram of tranexamic acid, you are already starting to hit the partial inhibition. And within 11 minutes, you're hitting the substantial inhibition. And even in shocked patients, in fact, the shocked patients, it's higher because part of the reason is because the drug is excreted renally, excretion is reduced in shocked patients, but absorption isn't. Okay, so because of the time to treatment interaction we saw, and the fact that there's so many women who really can't afford to lose any blood at all, especially women with severe anemia, we wondered about whether tranexamic acid can prevent postpartum hemorrhage happening in the first place. And this is what the Woman 2 trial is aiming to answer. So we're doing a randomized double-blind placebo-controlled trial. Will include 10,000 women with moderate and severe anemia. And they'll be randomized to receive either a gram of tranexamic acid or placebo. And we want it to be given as soon as the umbilical cord is cut and no later than 15 minutes after the cord has been cut. And this is primarily to reduce transmission to the baby, because the placenta concentration is similar to the maternal blood concentration. So this is why we do it at cord clamping. This, as you can see from this, recruitment was going very well. That's the purple bars, and the black bars was what we had predicted was going to happen. So we started off really well in Zambia, Nigeria, and Pakistan. But as you can see, since March, it's been very flat. And obviously, everyone knows what happened then in terms of the COVID-19 pandemic. In Pakistan, the trial has stopped totally. In Nigeria and Zambia, we're still recruiting, but recruiting at a much lower level. Primarily because our staff are either affected by COVID-19 themselves, or they've been moved elsewhere to help look after COVID-19 patients. But also, many of the hospitals were seeing less women attending to give birth. And part of the reason we had to stop in Pakistan was because some of our hospitals were even turned into COVID-19 centers. And this is just to show you some baseline hemoglobin level of our participants to date. 2/3 have an HB of less than 9. In the trial, our primary outcome is a clinical diagnosis of postpartum hemorrhage, but we're also collecting secondary outcomes on quality of life measures and a 6-minute walk test, because what is PPH in a woman with an HB of 6? Yeah, because when you look at studies, most research now will say that you need to have someone with a blood loss of over 2 liters to classify them as a severe PPH to be counted in your primary outcome. We don't know what should be counted in anemia, and we'll be using some of our own data to look at what's happening in these women when doctors are declaring a PPH, etc. We hoped that we would have had the results for you we would have finished recruitment by July next year, and probably would have had the results by autumn next year. But at the moment, we don't know what's going to happen, because Pakistan is expecting a second peak after Eid, and Nigeria and Zambia are still recruiting at a much lower level. So at the moment, we have been severely affected by the COVID-19 situation. So other than to say thank you very much for listening, and I would love to have your questions. Yes, thank you.
Thank you very much, Professor Halima. Participants, kindly type in your questions on the Q&A chat box, and I'll be able to read them out, and Professor will give a response. We want to thank you, Professor, for sharing that background on the woman trial, and reminding us that tranexamic acid reduces death from PPH by 30%, which is so important to us, and also showing us the impact of treatment delay for severe bleeding. Today we've understood why we always see the 3 hours mark as no impact, and you've explained to us very well. And you've been able to share to us about the woman program, which has a couple of trials, and really including the Woman 2 trial, and sharing that difference between that and the woman trial. So thank you very much, and welcoming questions from participants. So as the participants are logging in to ask their questions, Professor, would you highlight a little bit more about your initial thoughts about the subcutaneous route, and that final finding, which you said was consistent?
Yes, we thought that the subcutaneous route was going to be potentially one of the routes that could be used. But I suppose it makes logical sense, because blood supply to the fatty layer is quite poor. And if you inject something into the fatty layer, it's released at a slower rate. And so basically the modeling just confirmed what we should really expect biologically.
Thank you very much, Professor, for that. And following on something which you mentioned earlier on the concentration needed for fibrinolysis, which we said was 10 to 15, you also did mention that in some instances you were able to see that 5 milligrams was effective in some cases. And if so, what percentage would you say in terms of your findings it was?
Yeah, I think when we're looking at that data, we shouldn't think in terms of effectiveness in patients, because that was only looking at biological markers of fibrinolysis, so things like D-dimers, how well it can suppress those markers that you have when you have fibrinolytic activity going on, because tranexamic acid is an antifibrinolytic. It should inhibit fibrinolysis. So, but the level that will make clinical sense at the lower end, we don't know how low it can be before it can inhibit clinical processes. So that is still an open question, but what we know is that the dose we used in the woman trial, for example, the 1 gram intravenously, will definitely be way above the level that we need for substantial inhibition. But it's how low we can take it. So, because if you have IV access, you should give it IV, because that is 100% bioavailable immediately you give it. Intramuscular looks as if it's then the next best thing. We don't imagine that intramuscular and oral will ever take away from IV in situations where IV is available. So that will always remain the gold standard. But what we're doing here is trying to look at what if, so if you can't give an IV, what's the next best thing? And if you, so we hope that next best thing based on the data I've shown you will be intramuscular. If you can't give an intramuscular, what else can you do? And we're hoping that the liquid might confer some benefit. It will never be as good as IV, but is it good enough to inhibit fibrinolysis enough to prevent women dying and to allow them to get it as quickly as possible?
Thank you, Professor, for those discussions. And just lastly, I'm sure many of the participants might be wondering, what about the parectal route? If you could comment as we wrap up.
Yes, this was a lovely question from someone previously, that when we were looking at routes, there was no available rectal route that we could find. And whether it can be absorbed through, where it's gone straight out of my head, tissue that lines the mouth and the rectum.
The mucosa.
The mucosa, there you are. Yeah, so whether tranexamic acid can be absorbed via the mucosa we're not sure, because it's used as a mouthwash for dental extraction procedures where you have significant bleed. And when they've looked at PK levels in where patients have just had it in the mouth, the levels have been really, really low. This is below the level that will have any impact on systemic fibrinolysis. So it could be why there's no rectal available, but we couldn't find a formula that we could have tested rectally.
Well, thank you so much.